This lecture covers the second half of chronic musculoskeletal conditions. Osteomyelitis is a severe infection that occurs in the bone, bone marrow, and the surrounding soft tissue. It can develop rapidly over just a few days or slowly over a few weeks. It enters the bone through direct or indirect entry. Indirect entry of microorganisms into the bone could be the result of a fracture or some type of blunt trauma to the bone. It could also be the result of an infection spreading from another area of the body, such as a gastrointestinal or respiratory infection. Direct entry usually occurs via an open wound, such as an open fracture, where the microorganisms are able to directly enter the bone material. It can also be due to some type of foreign body presence within the bone. One factor that can make osteomyelitis a difficult condition to treat is because if it happens in association with a fracture, as the granulation tissue grows and develops and turns into scar tissue, it can become avascular, making it an ideal site for microorganisms to grow and making it difficult for antibiotics to penetrate. Osteomyelitis can be either acute, lasting less than a month in duration, or chronic when the infection lasts longer than a month or has failed to respond to an initial course of antibiotic therapy. When assessing the patient for osteomyelitis, we would want to gather both subjective data and objective data. Subjective data collection would consist of interviewing the patient about any recent bone trauma, fracture, any type of open puncture wound, or other types of infections. We would want to know about their use of antibiotics or analgesics, any history of a recent surgery. We also need to know their IV and alcohol abuse. We would want to ask about their areas of pain, if there's been an increase in pain or any local tenderness, and determine if they're having any weakness, paralysis, or muscle spasms. In regards to objective data, we're going to look for a temperature. Something that is noted with especially acute osteomyelitis is the tendency to spike a high temperature and experience night sweats. They may have diaphoresis, erythema, warmth, or edema in the area of the infection. They also may have restricted movement of the affected bone. They may possibly have wound drainage if there is an open wound, and they are going to be at risk for having an additional spontaneous fractures. On their labs, we would notice an elevated white blood cell count, positive blood cultures, and an elevated erythrocyte sedimentation rate. Patients may complain of nausea, a feeling of general malaise, and as the infection develops further, if there is an open wound, drainage can be evident. However, this is a late sign of the development of osteomyelitis. One significant feature of osteomyelitis is the pain that is associated with this. It's unrelieved by rest, and it generally worsens with their activity. In contrast with chronic osteomyelitis, this is when the patient's infection has lasted longer than a month, is not responding appropriately. We can see some subtle differences in the symptomatic presentation. Mainly, the systemic signs might be more diminished, such as the elevated white blood cell count or the fever. However, the local signs of infection are still going to be commonly present. So that's going to be the swelling, the redness at the site of infection, and possibly the drainage. The collaborative care of osteomyelitis will include IV antibiotic therapy for both the acute and the chronic forms. IV antibiotic therapy will consist of at least a 4 to 6 week time frame minimum in the acute patient. In the chronic patient, it's likely to be even longer and require the additional use of oral antibiotics along with the IV antibiotic therapy, and even continuing after IV antibiotic therapy may be completed. As part of the diagnostic testing with osteomyelitis, patients are likely going to have both wound and blood cultures taken and or a bone biopsy done to determine the type of microorganism that needs to be treated. They're also going to have some laboratory monitoring to keep track of their white blood cell count, also their erythrocyte sedimentation rate to examine for inflammation. They may also have additional x-rays, bone scans, MRIs, and CAT scans done to aid in the diagnostic process of osteomyelitis. Patients with acute osteomyelitis will likely have immobilization and careful handling of the affected limb. It's going to be important to address their pain through proper pain management. This applies to both the patient with acute and the patient with chronic osteomyelitis. However, the exhibition of the pain can be different. It can present itself differently in acute versus chronic. There will also be dressing change orders for both the patients with acute and chronic osteomyelitis. Dressing changes may follow surgical debridement and decompression in the patient with acute osteomyelitis, and dressing changes may be more involved in the patient with chronic osteomyelitis. They can consist of antibiotic irrigations of the bone, possibly antibiotic impregnated bead chains being implanted into the wound. They may have orders for negative pressure wound therapy, otherwise known as a wound vac. Some even have orders for hyperbaric oxygen therapy in order to help heal the wound. If the infection developed as a result of a hip or knee replacement, for example, it might be necessary even in the patient with chronic osteomyelitis to actually have the prosthetic device removed. This can also require muscle flap, skin grafting, and even bone grafting to be done in order to heal the affected area. Casts or braces may be necessary to support the weakened bones. Whether it's an acute or a chronic patient, some of their care can be completed at home or in a skilled nursing facility. They won't necessarily remain an inpatient for the entire duration of their treatment. It's also going to be important to provide patient teaching regarding any adverse reactions that may be associated with the antibiotics that would be prescribed for them. This could include things such as ototoxicity, nephro or neurotoxicity as well, any GI symptoms to watch for. Tendon rupture is also a risk, especially with the fluoroquinolones. So those are things we would want to make sure that we taught the patient regarding their specific type of antibiotics. Also, depending on the type of antibiotic they're on, it's possibly going to be necessary to monitor the peak and trough levels for certain IV antibiotics that are used to treat osteomyelitis. Also, keep in mind that the length of antibiotic therapy that's required for this type of disorder can result in the overgrowth of fungal infections such as Candida albicans. So we would want to keep an eye on the possibility of superinfections as well. Last but not least, in the patient with chronic osteomyelitis that has been unresponsive to antibiotic therapy or wound therapy, the biggest complication they may face may be that if treatment remains unresponsive, they may have to have an amputation of the affected extremity. In cases of chronic osteomyelitis, even with treatment, they do only carry about a 50% success rate. So amputation is not an unlikely possibility for patients with chronic osteomyelitis. Osteoarthritis is the most common form of joint disease in the United States. Over 27 million Americans are affected. Over 50% of individuals over age 65 have at least one joint affected by osteoarthritis. Although this is very common, it is not considered a normal part of the aging process. Additionally, we do see osteoarthritis present more frequently in women than in men. Generally speaking, the cartilage destruction associated with osteoarthritis begins between the ages of 20 and 30, but symptoms do not generally manifest until after age 50 to 60. Some of the most common risk factors for osteoarthritis are the patient's age, their estrogen reduction experienced at menopause, obesity, any history of injuries, and occupational frequent kneeling and stooping. The condition develops as a result of cartilage becoming dull and granular, making it soft and less elastic. Over time, the joint slowly becomes less able to resist wear with heavy use. This leads to erosion of the articular surfaces and ultimately the formation of osteophytes. CAT scans, MRIs, and bone scans can detect some early joint changes. X-rays can detect joint space narrowing, bony sclerosis, and the osteophyte formation. The synovial fluid analysis may be done because it is possible for secondary synovitis to develop as a result of osteoarthritis progressing. Joint pain is the predominant symptom with osteoarthritis. It can range from mild discomfort to significant disability. The pain is often referred to the groin, buttock, or medial sides of the knee or thigh. Sitting down can become very difficult, as does getting up from a chair when the hips are lower than the knees. This is the case when osteoarthritis is predominantly in the lower extremities. Osteoarthritis affects joints asymmetrically. It is specific to the involved joint. We often refer to osteoarthritis as a wear and tear type of disorder. It's going to occur in the joints that are most often used. For example, if an individual was to work in a factory for 30 years managing a particular type of machinery with their left arm, they would likely develop arthritis in that arm, possibly that wrist and the fingers and the elbow of that affected arm, even likely the shoulder, with the right arm remaining unaffected. When arthritis develops in the lower extremities, gait problems can also develop. Arthritis in the knee can lead to problems with the patient being bow-legged or having an altered gait. Arthritis in the hip can lead to one leg being shorter than the other. Other problems with osteoarthritis that develop are joint stiffness. This tends to occur after periods of rest or after periods of being in a static position. Pain tends to actually worsen with the joint use. Early stages of osteoarthritis, the patient will have relief of pain if they rest the joint. Later stages of osteoarthritis, the pain will be pretty consistent. It'll be present with rest and sleep, will be disturbed because the pain and the increased joint discomfort. Early morning stiffness is something that can be seen also with osteoarthritis. This usually resolves within 30 minutes of awakening. The pain that becomes more frequent associated with advanced osteoarthritis occurs because of the contact that is created between the exposed bony joint surfaces. So what we have as the disease advances is actually bone on bone. This creates a significant increase in the patient's pain. It also creates what is known as crepitation. And crepitation is a crackling or grating sound that is caused by those bones rubbing together. One other symptom that we can see with advanced osteoarthritis is going to be the development of Heberden's nodes and Bouchard's nodes. These are bony swellings that form on the fingers and the toes as a result of abnormal bone growth. Heberden's nodes are swellings that form on the distal joints of the hands. Bouchard's nodes form on the proximal joints, such as the middle joints of the fingers or toes. These can appear red, swollen, and tender. They don't really cause a significant loss of function, but they do cause a visible disfigurement. And they're generally non-inflammatory conditions. Collaborative care for osteoarthritis consists of a balance of rest and activity. Patients should use ice during periods of acute inflammation. They should also use functional positioning, putting the joint in a position that is most comfortable to them. And we do not want them to keep that joint immobilized for greater than a week, as this can exacerbate the condition. For stiffness, they can use heat therapy, such as hot packs, whirlpool baths, or paraffin wax. Another recommendation and part of a care plan for osteoarthritis is going to be weight reduction. If a patient is overweight, this is going to greatly contribute to the development of osteoarthritis, especially in the lower extremities. Patients may need counseling regarding dietary changes and exercise plans. We would also recommend that patients with osteoarthritis modify their activities to decrease joint stress. They should avoid prolonged standing, kneeling, or squatting. If they have knee osteoarthritis, they may need to use some assistive devices such as canes or walkers. And drug therapy would be prescribed to serve as an adjunct to our non-pharmacological treatment methods. Drug therapy is going to be based on the severity of the patient's symptoms. For mild to moderate joint pain, we would recommend acetaminophen therapy and topical agents such as capsaicin cream or diclofenac gel. Over-the-counter creams such as Bengay or BioFreeze are commonly recommended for mild to moderate joint pain as well. And topical salicylates such as Asper cream is another option. As pain progresses and develops to moderate to severe joint pain, they will recommend that the patient start a therapy of NSAIDs, non-steroidal anti-inflammatory drugs. This can consist of medications such as ibuprofen over the counter or diclofenac as prescription. With routine NSAID administration, patients become at higher risk for the development of GI side effects and possibly ulcer formation. Therefore, usually it does become necessary to add on some anti-ulcer agents. Misoprostol is a medication that's commonly administered to patients on routine NSAIDs to help decrease the risk of ulcer formation. Arthrotek is a brand name combination drug that combines both misoprostol and diclofenac into one medication to take each day. Another pharmacological treatment option for severe osteoarthritic pain is the use of COX-2 inhibitors such as celecoxib. Celecoxib is otherwise known as Celebrex. This is a medication that works by blocking the enzymes in the body that make prostaglandins. Decreasing prostaglandins helps to reduce the pain and swelling associated with late-stage osteoarthritis. As osteoarthritis continues to develop, these medications may well fail to properly cover the patient's pain as well. At that point, oftentimes patients may opt for intra-articular corticosteroid injections. These are steroid injections that are placed directly into the affected joint. They do cause some temporary relief of discomfort. Patients are limited on the number of times that they can have a steroid injection. Oftentimes, steroid injections cannot be administered any more frequently than every 3 to 4 months. And most of the time, the steroid injections only last the patients about 1 to 2 months, depending on how severe the osteoarthritis is. Another option is the injection of hyaluronic acid into the joint space. Hyaluronic acid is a naturally occurring substance that's found in the synovial fluid surrounding joints. It acts as a lubricant to enable the bones to move smoothly over each other, and it also acts as a shock absorber for joint loads. People with osteoarthritis tend to have a lower than normal concentration of hyaluronic acid in their joints. So the theory is that by adding this to the arthritic joint, it can help to facilitate the patient's movement and reduce some of their pain. Another option for osteoarthritis would be arthroscopic surgery, as discussed in the assessment lecture. This is usually done for patients who are less than 55 years of age. It can help to delay the need for a knee replacement. It can help to remove some of the debris and clean up the joint and improve its functionality for a limited time. Ultimately, when other therapies fail to be effective in the treatment of osteoarthritis, frequently patients eventually turn to a joint replacement surgery. This is known as arthroplasty. Some of the most common joints that are replaced are the hip, knee, elbow and shoulder, and the ankle. Hip and knee are two of the most commonly performed surgical procedures in the United States each year. A joint replacement surgery is done for intractable pain that has become disruptive to the sleep and the patient's activities of daily living. It does do a great job at relieving the patient's pain and restoring their function. Post-op considerations for the patient who has just had arthroplastic surgery would consist of ensuring that they're able to turn, cough, and deep breathe in order to prevent atelectasis. Patients will be out of bed the same day for early morning surgeries and will be out of bed by the next morning for afternoon surgeries. It's really important that we get them up and moving on that new joint as soon as possible. This helps to reduce respiratory complications and the risk for the development of DVT. In addition, we will also recommend that when they're in bed, they perform active range of motion foot pumps every hour. Patients with knee surgeries are going to be placed on a CPM, a continuous passive motion machine, to keep the joint from stiffening. This will promote movement within the joint. They will have orders regarding the amount of time they have to be on the CPM machine each day, and they'll have orders for increasing the bend or the angle of the knee each day. Patients with knee replacement surgery will also use ice packs changed frequently throughout the day, at least 3 to 4 times a day. For patients with hip surgeries, we do recommend that they do not bend the angle of the hip more than 90 degrees in the sitting position. This can cause dislocation, especially of the traditional hip replacement. There are some newer hip replacements out there, newer types of prosthesis that carry a lower risk of dislocation. if a patient was to exceed that 90-degree angle. But as a general rule of thumb, we like to keep patients we like to keep them avoiding to increasing that angle beyond the 90 degrees. Some other postoperative considerations would be to make sure the patient is taking their anticoagulant therapy. All patients following arthroplasty surgery are going to be on anticoagulants for a period of time to prevent DVTs. We're also going to want to assess the condition of their wound. They're going to have a dressing in place. We'll have orders to change that dressing at some point, usually anywhere from about 2 to 4 days post-op. Some surgeons leave the dressing in place for longer than that, but we would just want to follow our surgeon's orders. If we do remove the dressing and assess the site, we want to examine the staples. We want to make sure we look on the surface of the dressing or the wound once we change the dressing for any drainage. And you also want to be sure to do frequent assessments for circulation and sensation in the affected extremity. The last disorder that we're going to cover in this lecture is gout. Gout is a type of recurring acute arthritis that is characterized by uric acid crystal accumulation in the joint space and the surrounding tissues. It is caused by an excess of uric acid, which is a waste product made by the body. And this either results from excessive uric acid production or a decreased uric acid excretion by the kidneys. What happens with gout is that the uric acid forms what we call urate crystals. These crystals collect in the joints, triggering a gout attack. If a patient has several gout attacks, the crystals may begin to form large deposits within the joint known as tophi. Tophi can damage the joint and cause deformities. Tophi is spelled T-O-P-H-I. Gout can affect any joint in the body, but the big toe is most frequently affected. About 75% of gout attacks occur in the big toe. However, it can also affect joints such as the ankle, the heel, the knee, wrist, elbows, fingers, and even spine. Gout can be primary or secondary in occurrence. Primary gout occurs specifically because of the overproduction or the retention of uric acid. Secondary gout occurs usually due to other types of medication causing problems with excessive uric acid accumulation. Gout occurs in 4 stages. Our first stage of gout is known as asymptomatic hyperuricemia. At this stage, there are no symptoms present in the patient other than an elevated uric acid level if labs were to be drawn. The second stage of gout is known as the acute gouty arthritis stage. This is when abrupt, severe crushing pain occurs most often at night. It's so severe that the patient can't even stand to have the bed sheets touching their foot. Oftentimes, this stage is triggered by alcohol or a high-protein diet. The third stage of gout is known as the asymptomatic intercritical period. This is a period where the pain associated with gout resolves. However, the crystal collection that I mentioned earlier is still occurring, and it is going to eventually lead to the fourth stage, which is known as chronic tophaceous gout. And the fourth stage develops when the urate crystal formation has accumulated to the point that those deposits have formed under the skin and the tophi have developed, and the joint has begun to become disfigured. Gout is more common in men. It's also more commonly associated in patients who are obese, in patients who have excessive alcohol consumption, patients who utilize diuretics, and patients who have diets high in purine-rich foods, such as shellfish, asparagus, spinach, beef, chicken, and pork. Oftentimes, the diagnosis of gout can be placed with the history and physical of the presenting symptoms along with the uric acid levels being elevated. However, definitive diagnosis can come from the presence of urate crystals found in synovial fluid that is actually aspirated from the joint. Normal uric acid levels should be between 2 and 7. Elevations found above 7 are going to be used to support the diagnosis of gout. As far as treatment for gout, our treatments are going to be aimed at the reduction of the inflammation. The most commonly used medications are allopurinol and colchicine. These are both considered anti-gout agents. They do both work a little bit differently. Allopurinol is used to reduce the frequency of the gout attacks. It prevents the production of uric acid. It is important to make sure that the patient is aware that they should avoid aspirin when taking allopurinol, as it reduces the effectiveness of the medication. Colchicine is our other anti-gout agent that we will frequently see administered. This is used for acute flare-ups of gout, and it acts as an anti-inflammatory by reducing the swelling and pain. It's important to note that allopurinol should be taken routinely, and it will not be effective during an acute attack. But that doesn't mean that the patient shouldn't continue to take it. They should. They should just know that it is not going to provide relief of symptoms as well as the colchicine is. Other medications that may be prescribed for gout include NSAID therapy and corticosteroid therapy.